Not working like this. The sound, I will try to comment on the surgery here. Okay, we start with the prone position with the straight AP here, and then we bend the table also to open the interlaminar window and stretch the flow ligament here. And the next step is marking the entry point here. Okay, we mark the interlaminar window now, as medial as possible here, as you see. Here, as medial as possible. Not all.
Hello. Hello.
Yes, sir. We can hear you, sir.
You can hear me now. I couldn't hear you till now. Now I just heard you. Now you can hear me well, no?
Yes, sir.
So should I start?
Yes.
We'll start in 10 minutes, sir.
Okay, fine. Take it. What is the protocol, Sajjot? If I want to ask a question which I want people to respond, then how do I just put up the question? What will happen? I require a strong one for this 1 hour seminar. So this is full of grey goose. So how does one, Sajjot, can you hear me?
I can hear you, sir.
So suppose somebody has a question, how does he ask me a question? Or suppose I ask a
question. When you start, we'll mute everybody first. So whoever has to ask question will unmute himself and ask you a question, and then again go back to the mute mode.
Okay.
If you want to ask someone, you can call up the name. I'll unmute them from here.
Okay. All right. Sure.
Yes.
That makes
We'll
sense.
start in 5 minutes. Exactly 5 o'clock we'll start. We are going live now on YouTube. Once we are done that, we'll go live.
Kedar, what's up?
मजा में
कितना कोरोना का पेशेंट्स को ऑपरेट किया अभी तक?
एक भी नहीं. Have you operated on corona?
I have not moved out of my house for 15 days, my friend.
Same here.
I stopped 7 days before the official lockdown was announced. I locked myself down.
Preemptive strike.
Preemptive strike कर दिया मैंने. मंजन करने का मजा है. It's a lovely holiday. Why should you waste it?
Absolutely.
Hi, Ranjit. I can't hear you. How are
Can you hear me, sir?
Yeah,
Fine,
very
good.
well. How are things in Kerala?
Good going on, sir. Maximum number of corona patients.
Yeah.
Maximum corona is in Kerala.
You haven't operated anywhere, no?
No corona yet.
Lot of corona in Bombay is from patients who have come from Dubai.
Same here. The maximum is from Dubai. 70% is from Dubai.
Yeah, and some is from Italy. Some people came from Italy to Bombay.
True. Same here, sir. Same here, sir.
I'm sure. Sorry, Aditya, I don't recognize you, Aditya.
It's a Caesar. And now once more, we need to check the direction.
Hi, sir.
Hi, Aditya.
I think there are two Aditya. Yeah, hi, sir.
Oh, apna ye to this is Sion Hospital ka Aditya na? I can't see
No,
you.
sir, I am from KM.
हाँ KM, अच्छा. Oh.
Yeah.
There are 3 Adityas.
There are 2 Adityas there.
Here, this is another Aditya who has come. Kashikar. Oh, Vishal is calling. Just 1 second. हाँ विशाल बोलो.
you see the synovium, and then it's very sensitive to the radio frequency. You can easily change the synovium with the radio frequency like this. And you see the apex of the ascending facet. This is descending facet. This is ascending facet, and this is the apex of the ascending facet here.
ઓહો ડોક્ટર આચાર્ય બી આવી ગયા છે. ડોક્ટર આચાર્ય,
Yeah, sir. Very good.
અમદાવાદમાં બધું
અમદાવાદમાં લોકડાઉન.
લોકડાઉન જ છે ને, અમે બધા લોકડાઉન. આજ સુબે I went from Ghatkopar to Fortis Hospital, Mulund, to see a patient. I was stopped by the cops 3 times. 3 times the police stopped me. અરે ભાઈ ચાર્જર આપી દે અપૂર્વ. અપૂર્વ ચાર્જર આપો ભાઈ.
આપ્યું ને, હવે શું છે?
પેલા મમ્મીને always remember.
Gautam sir, how are you?
નથી સંભળાતું સરને નહીં સંભળાતું.
અવાજ બેટા શું ચાલે છે?
Good evening, everyone. We have with us Dr. Gautam Zaveri, who's going to be the speaker for the evening, and the topics are metastatic spinal tumors. With us, we have a big panel of panelists around with us. Before we even start into the game, let me set the game of the rules of the game set. We are all going to be on mute mode. The only person on unmute to begin with will be Dr. Gautam Zaveri. It's very, very important that we all remain on mute mode so that there is less disturbance online. Also, it reduces the burden on web and internet services. The moment we want to ask a question, we can either unmute ourselves, stop the speaker, introduce yourself and pose a question, or there is a chat option on the screen. You can just put a question there, and we have all the panelists who will immediately take up this question and answer in the chat mode itself. Dr. Gautam will be speaking and taking care of all the issues regarding metastatic spinal tumors, right from the patients where there is no pathological collapse, no neurology, to all the way patients with multi-level metastatic disease. We are going to address all the issues into this. If there are any issues that are left behind, we will have significant time left over for question answer sessions, which we will utilize to not only ask Dr. Gautam, but also the panelists around. Dr. Gautam has made interactive cases also to keep all the delegates involved. We are going to start at 5 o'clock. Let me introduce and invite our panelist, Dr. Priyank Patel, who's from Mumbai, has special interest in spine tumors. Dr. Kedar Degaonkar has humongous experience on sacral tumors and chondrosarcomas and chordomas. Dr. Amit Sharma, who's again a pioneer of transpedicular posterior decompression. How is it of use in metastatic spine? Dr. Gautam will highlight us. Dr. Abhay Nene, Dr. Sameer Dalvi, senior panelist with us from Mumbai. We have Dr. Neeraj Vasavada, Dr. Ranjit Unnikrishnan, Dr. Guru Raj, and Dr. Umesh Shrikanta from nationwide around from various zones of the country. May we have Dr. Gautam's screen now being shared online, and we hand over the proceedings to Dr. Gautam. Dr. Gautam, you have your panelists online, and we are all around listening to you keenly. At the end of the talk, I have some articles which I will share with you. As of now, to begin with, while Dr. Gautam starts, I'm going to share few articles to begin with while Dr. Gautam shares his screen there. Dr. Gautam, over to you.
Yeah. So thank you, Vishal, for getting me here. And on behalf of the Bombay Spine Society, I would like to invite and thank all of you for joining us on this webinar on spinal tumors. In this webinar, we are going to focus purely on metastatic spinal tumors, not on primary spinal tumors. We will be dividing it into two parts. The first part of that webinar is that we will have a lecture on basics of metastatic spinal tumors, which will include the basic information about epidemiology, pathology, etc. And we'll go on to current treatment rationale on the management of spinal metastatic tumors. The second half will be interactive cases where I will put up the case and we can discuss what are the treatment options for this. And as finally, the last part of this is going to be that Dr. Vishal Kunnani will share the various papers on this subject with you. Now, you are welcome to speak during the interactive case discussion, but please do not interrupt me during my lecture. Let the lecture get over. Whatever questions are there, you can ask me at the end, or you can with chat with any of our expert panelists so that they will be able to help you with the session. So let me start by starting with a case to start with. We are at 4:59. Vishal, should I go ahead and start?
Yes, sir. Please, sir. Just one small request. It is better if you speak directly on the microphone rather than the speakers and headphone, because sometimes there is a vibration in the headphone resulting into voice vibrations. So maybe you can directly speak on the computer if you have a microphone on the computer.
I am speaking directly onto the computer. These headphones are only for me. They do not have a mic with it.
Okay.
Yeah.
Okay, perfect.
So can you see my case one? I've shared it on the screen.
Yes, we can.
All right. So let us start with this first case. This 25-year-old lady presented to a spine surgeon with severe back pain, which was there for 2 months. She had weight loss, anorexia, and low-grade fever. She had a lot of tenderness over the lumbar spine. Movements were painful and restricted. She had lost 7 kgs in the past 2 months. That there was no neurologic deficit. Her total counts were normal. Lymphocyte was 40%. ESR was elevated. CRP was elevated. An X-ray and an MRI scan was done. X-ray showed some destruction of the vertebra over here at 5432L2, and which was asymmetric. And there was a little bit of collapse over here. The MRI showed that there was a pathological fracture of the L2 vertebral body, and there was some kind of a soft tissue mass which was protruding posteriorly. As you can see on this axial view, it was more towards the right. Now, the first question which goes out to Dr. Kishore Kumar, who has already joined us. Dr. Kishore Kumar, are you here, Kishore? How should we proceed in this case? Would you do any other investigations? Would you start with antituberculous treatment? Would you do radiotherapy in this case, or would you think of surgery directly? What would be your treatment of choice, and how would you go ahead and do this? Kishore, have you seen the case? So this is the picture of a 26-year-old.
Yeah, tell me.
26-year-old girl, 2-month history of severe back pain. She had lost weight of about 7 kgs in 2 months. She was in severe back pain, and she has approached, but no neurology, no leg pain. She has approached a spine surgeon. This is the X-ray and MRI picture. What would you do? Would you do any other investigations? Her total count is normal. ESR and CRP are slightly elevated. Would you start with
other investigations? She'll need a CT guided biopsy.
Tata, Gautam.
So you would do a CT guided biopsy in this patient. Yeah. Jwalant, are you there on the slide? Jwalant Patel.
Yes, sir.
Jwalant,
Yeah,
Jwalant, what will you do here?
So considering the clinical symptom, patient is having normal neurology, so I will do biopsy, either CT guided or fluoroscopy guided.
What about any other blood investigations? What about a Mantoux test? You know, we are thinking this might be tuberculosis. This is an Indian patient. Don't you think that should we do an IgG, IgM, which will help in helping the diagnosis, or would you directly want to go for biopsy in this patient?
But sir, according to the recent literature, the IgG and IgM is having low sensitivity, as
Very
well
good.
as the Mantoux test also in the India. Patients are usually getting the BCG vaccine, and so it is also not very sensitive.
Right. I think that's a perfect answer from Jwalant and from Kishore, that in India, IgG and IgM has been banned actually by the government of India. It has been found to be very low in sensitivity and specificity. Yeah. The Mantoux test is positive in almost all Indians and therefore not really a very useful test. And therefore, if you want to diagnose this further, then some kind of a biopsy is the way to go. Saijot, what about starting directly anti-tuberculosis? I mean, this is India. Come on. I mean, patient has got a clear lesion. Why not just start anti-tuberculosis treatment here?
No, sir. Without the biopsy, we would not go ahead with the AKT.
Without biopsy, you would. What sort of biopsy do you do? Would you agree with Dr. Kishore, who wants to do a CT-guided biopsy, or is there some other thing you do?
So here we can go ahead with the CT-guided biopsy.
Okay, Ranjit, are you still around? Ranjit Unnikrishnan.
Yes, sir. Very much. Very much.
Ranjit, what would you do?
Same standard plan. First biopsy.
What sort of biopsy?
I personally, than CT guided, I'll go for transpedicular biopsy because of my settings. I want to have a diagnosis. I don't want to waste time with CT. So I will do a transpedicular biopsy. That's it.
Good. So I think almost everybody agrees that before starting anti-tuberculosis treatment, you must do a biopsy. What is in biopsy? What is recommended is that you get a core biopsy, not a FNAC. It can be done through a transpedicular route in a fluoroscopy manner. It can be done CT guided. But the problem is most CT scan people do a fine needle aspiration cytology. They have used a very thin needle, and therefore the amount of material you get is not enough, and it can only be done FNAC. You can't actually do a proper histopathology and preparation, and therefore the diagnostic yield is very low. So if you're going to get your radiologist to do a CT guided, please ask him to do a transpedicular core biopsy rather than to do a FNAC. In my practice, I do a fluoroscopy guided transpedicular core biopsy in such a patient. However, unfortunately for this patient, the spine surgeon concerned decided that there was enough evidence here to suggest that this was tuberculosis and put the patient on a 4-drug AKT. 1 week later, she still had persistent severe back pain. 1 month later, I got involved in the patient's history when one fine morning she lost power in both the legs, and the family called me up urgently to come and see the patient. I saw the patient. She was paraplegic. I took this patient up for surgery within 6 hours, decompressed the canal, stabilized the spine. This was the picture just before we operated the second operated. This is what we did. We went in anteriorly, did a corpectomy and stabilized, did a posterior fixation. And this patient turned out to have a lung cancer with metastatic spinal disease. And therefore, the important message to all of you people who are here in the audience is that it is vital to confirm diagnosis, even though it is so common in our country. It is vital to confirm diagnosis of tuberculosis before starting AKT. In a patient who has a pathological fracture, which is a central body type of lesion, the diagnosis can also be an osteoporotic vertebral fracture in the elderly. It could also be a primary or a secondary tumor, and therefore a biopsy is absolutely vital. A fine FNAC, which is what you normally get with a CT guided biopsy, has a very low yield. What you must aim for is a core biopsy using a 10 or 11 gauge needle. Dr. Janardhan Aitala from Bangalore has a beautiful paper on this, and it might be worthwhile reading this. It has a higher success rate because it gives a larger tissue sample. Now, having started off the discussion with this case, I want to move on to the lecture on metastatic spinal tumors. And let us move on. Now, for those of you who are joining us late, I can see Dr. Bapat has just joined
Dr.
us.
Gautam, can I ask a question? There is a question from a delegate here around.
Yeah.
What are the investigations that you suspect in a patient with a lesion on MRI that are to be done before considering biopsy?
So I think in any patient who has got an MRI which shows a central body kind of lesion where you're planning to do a biopsy, you must do all sorts of blood tests. So CBC, ESR, quantitative CRP, a protein electrophoresis to rule out multiple myeloma, a BUN creatinine to see if there is any abnormality in renal function, liver function, thyroid function, if it's a male, a PSA level are some of the tests you could do. Not everything is done in every patient. Other than that, I would also suggest that if there is any doubt, if the patient has had a previous history suggestive of any malignancy elsewhere, and this is suspected to be a metastatic disease, or for that matter, if any reason you think this is a tumor, it might be worthwhile getting a PET scan to see if there are any lesions elsewhere in the body, which will help you to decide that yes, in fact, this is a tumor and not an infection. So this is how I go about it, and we will go on to more of this as we discuss. Somebody has their background music on and I can hear their family members speaking. I would be grateful if that can be.
Can I request all the participants to please go on mute mode? May I request all, Sai, can you put all of them on mute, please? Sai, you have the control to put everyone on mute.
All the participants, the young participants here, spinal tumors can be of two types. They can be primary tumors, or there may be a tumor somewhere else in the body which has spread to the spine, in which case this tumor which has spread is called as a metastasis. And the secondary effects of the metastasis on the spine, namely pathological fracture, instability, deformity, constitutes what is called as a spinal metastatic disease. In the good old days, patients with metastasis used to hardly survive, because by the time it is metastasis, there is stage 4. But with modern chemotherapy, hormonal therapy, radiotherapy, and aggressive surgery, patients with metastatic disease are surviving longer and longer. And therefore, we as spine surgeons come into play because these patients are referred to us for treatment. By the time a person dies, it is estimated, if you do an autopsy on these patients, almost 80% of them will have a metastasis in the spine. Spine, in fact, is the most common organ after lung and liver to develop a metastatic disease. In a paper I did, which was published in 2003, we looked at about 600 patients. And what we found was that most common primary tumors that metastasize to the spine include firstly breast, lung, and prostate. These are the most common. These are followed by kidney, thyroid, and then of course colon, sarcomas, GI tumors, etc. What are the portals? How does the spine, the metastasis from a primary tumor spread to the spine? It can spread via the arterial route, the most common among them being the lung. It can spread via the Batson's venous plexus because of back pressure changes, which is commonly seen with prostate. Breast tumor spreads to the spine through the lymphatic route. And of course, tumors which are close to the spine can contiguously spread to the spine, such as thyroid cancers and retroperitoneal tumors. Within the spine, there is some controversy as which is the most common region. Some people believe that thoracic spine metastases are most common. Others believe that the bone marrow within a lumbar spine is much more. And therefore, it is the lumbar spine which has the more common with more metastasis. Lumbar spine metastasis more commonly cause a lot of pain. In the thoracic spine, the rib cage supports the vertebral body, and therefore these patients don't get a lot of pain and they often present directly with neurology. Metastasis on the cervical spine is rare. It is in about 8% of patients. The subdural or intradural metastases are even less common. Within the vertebral body, the metastasis is much more common within the vertebral body than within the posterior elements. But you must remember that unlike in tuberculosis, where you see spread of the pus or infective granulation tissue subligamentous below the ALL, below the PLL, across the disc space, you do not find that in tumors. The disc is in fact resistant to metastatic invasion. 40% of patients with spinal metastasis are completely asymptomatic. So often it is detected by chance when you are investigating for something else. I've had 2 or 3 patients who came with back pain. We did an MRI and it turned out there was a metastatic lesion there. And when we further investigated, we found that in fact this patient had a renal cell cancer, which was undetected till then. Clinically, as the metastasis usually starts in the posterior half of the vertebral body, then involves the pedicle and makes the vertebral body weak. And therefore, there is pain, there is instability, there may be pathological fractures. And as the epidural space gets more and more obstructed, there may be a risk of neurologic deficit. And if multiple vertebrae are involved, thus you can find deformity. Any patient who has a thoracic pain, a night pain, a rest pain, a pain which is not mechanical, it is continuous in origin, not associated with posture, definitely needs further workup. A patient who complains of pain for the first time and his age is less than 20 or more than 60 years old, he requires attention also. All patients with any kind of pathologic fracture which has occurred without any trauma, one must rule out metastatic disease. Now that brings us to the next stage, that how do you investigate a patient who comes with a solitary vertebral collapse? Well, the steps are very clear. The first thing you do is try to delineate the local extent of the disease. Is the disease only in the vertebral body? Has it spread into the spinal canal? Has it spread in the tissues around the spine? So you want to find the local extent of the disease, and the investigations which help you best are an MRI scan and a CT scan. You then are looking for an etiology and you want to see how much it has spread. To look for the spread of the tumor, one of the best investigations today is a CT PET scan. The CT PET scan, which is FDG with a FDG tracer isotope, is an extremely sensitive investigation which helps you to detect metastases which are even 2 millimeters big within the visceral or in the skeletal system. Also, to identify the origin of the unknown primary, the CT PET scan is extremely useful, but a number of blood tests, as I will outline later, are to be done. Usually, a biopsy is done following all other non-invasive investigations. If you do a biopsy before you've done an MRI or something, it may alter the MRI picture and therefore it should be avoided. As a resident, what do you see on an X-ray? Well, on X-ray, you might find a lighting defect, which means destroyed bone. Or if this is a tumor which is throwing bone, like a prosthetic tumor, you might find osteoblastic lesion. As you can see, sclerosis or osteoblastic lesion in the right half of the pelvis here. You may find a pathological fracture of the vertebra over here. Or you may see a winking owl sign, which means that the pedicle is destroyed on one side, but you can see the eye of the pedicle on the other side, which is normal, and that is called as a winking owl sign. The limitations of X-rays are that 40% of lesions are missed on plain X-rays. Lesions can be only seen if they are more than 1 centimeter in size and when more than 50% of bone is lost. And of course, soft tissue lesions and epidural metastasis will not be seen. The investigation of choice initially is, of course, the MRI. The advantages, you can see early bone marrow infiltration. You can see the extent of bone destruction. You can see if there is any spread into the epidural space and whether there is any cord compression, any extension into the soft tissues. What you can also see, as you can see very clearly here, is tumor vascularity. You can actually see the blood vessel indicating that this is a very vascular tumor, or you may see flow voids like this, which indicate that the tumor is hyperintense and therefore vascular. And of course, you can pick up lesions along the spine, other lesions like you can see in this case over here, where you can see a problem. The next set of things to do are the blood tests. Hemoglobin is done. Often, most of these patients have anemia. Especially, you would find anemia in patients with multiple myeloma. Total WBC count is therapy or chemotherapy. The count may be reduced. Platelet counts may also be reduced. You must do a renal profile to look for the creatinine. You must do a liver function test in order to find out what's going on. Thyroid metastasis to the spine is not uncommon, so do thyroid function tests. Protein electrophoresis, multiple myeloma is the most common primary malignant tumor of the spine. Serum calcium phosphorus alkaline phosphatase, PSA levels in case of males, and if you're suspecting lymphoma, sometimes the LDH and uric acid are elevated. A CT scan is not commonly done in a patient in whom you are planning to treat non-operatively. However, the advantages of a CT scan is that it offers excellent bony delineation of the tumor. It detects cortical breach and predicts the possibility of impending vertebral collapse. However, the problem is that if you are looking for it to diagnose the tumor, then it is less sensitive than an MRI. It's difficult to assess the extent of soft tissue spread on a CT scan, and of course, radiation exposure is more. Brings us to nuclear imaging. In the past, all these things were tested with a technetium bone scan, which is an extremely good test for initial screening to look for skeletal metastasis and to differentiate these from other problems. However, what is now available in most places is a CT PET scan. Using an FDG isotope, it detects early glucose metabolism of the neoplastic cells within the bone and bone marrow. It has a 98% sensitivity in detecting the skeletal metastasis. It is more sensitive for detecting lytic mets than sclerotic mets and may help to differentiate between metastasis and osteoporotic vertebral fractures. What is available also for diagnostics is the possibility of doing a whole body MRI, which is an extremely good test because you can see both skeletal as well as visceral mets. However, it has a very long acquisition time, almost takes an hour, and is extremely expensive. That brings us finally to what we all were talking about, and that is biopsy. You must remember that whenever a lesion like this is there is no room for empirical treatment. The biopsy, even if it is a tumor, tells you what is the type of tumor, what is the gradation of the tumor, and how sensitive it is to chemo or radiotherapy. And therefore, histopathological confirmation must always be done. There are various methods of biopsy: USG guided, CT guided, which is an FNAC, a transpedicular core biopsy, or finally, sometimes we do an open biopsy when a patient is paralyzed or something, and you already are planning to do a surgery for this patient. Then you do an excisional biopsy in these patients. That brings us to the treatment. What is the treatment option for these patients? You must remember that when the tumor has already metastatized, it means that this is already stage 4. It has already spread beyond its confines, and it's a systemic disease, which most of the times you are not able to control or cure completely. And therefore, the management of the tumor is primarily aimed at palliation. Palliation means that you have to make the patient comfortable and functional in the time duration that is the patient is alive. That is, you try to improve the patient's quality of life, but at an acceptable risk. The options for palliation include just simple pain control. You know this patient is going to live for 3 to 4 weeks. There is no point in doing fancy surgery. Instead, it might be worthwhile just giving adequate pain relief so that the patient can live a comfortable life. The other options are, of course, chemotherapy, which is done by the oncologists. But from our point of view, what is important in chemotherapy is steroids and bisphosphonates. The steroids which are used are helpful because they reduce the tumor size by reducing the edema, and they are very useful around the time when radiotherapy is given, because the tumor cells necrose and the tumor swells up and can cause actually worsening of the neurology temporarily. Also, in patients with whom you are embolizing, steroids are given peri-embolization in order to reduce the edema that comes along. Bisphosphonates, of course, most oncologists start this, but it reduces the incidence of skeletal deaths. The decision about chemotherapy and radiotherapy is made by the oncologists. And of course, there are various types of surgery: decompression alone, decompression plus stabilization, reconstructive spinal surgery, vertebroplasty, kyphoplasty. Decompression alone means a laminectomy alone, which was a common surgery in the past. Today, nobody does decompression alone for metastatic tumors for fear of causing a pathological fracture. So as I said, palliation, you must weigh the surgical morbidity, the anticipated survival of the patient against the quality of life in order to justify surgical intervention. Now, once you think about surgery, or once you have started treatment, you are thinking whether is surgery the best way or is radiotherapy the best way to treat this. Radiation helps because it reduces the size of the tumor mass, it reduces the bone pain, and in fact the tumor may melt and relieve the neurological compression. In the past, when laminectomy was the standard of treatment for patients with spinal tumors, studies were conducted comparing laminectomy with radiation, and it was concluded that radiation therapy is far superior to surgery. They found that there were equivalent rates of improving or maintaining neurology and ambulation and lesser morbidity. However, today, modern treatment is very different. When you did laminectomy alone, the disease is anteriorly within the vertebral body, and it's impossible through a laminectomy in the thoracic spine to approach the anterior vertebral body without retracting the neural structures. And therefore, anterior decompression was not adequate, so it didn't really help. Also, in a patient who already has vertebral body disease, the possibility of a pathological fracture, a laminectomy created a globally unstable disease, and therefore patients had more pain, more pathological fractures, and therefore it was concluded that radiation therapy is better than surgery. Today, we do these surgeries with stabilization so that pathological fractures don't occur. We go posterolaterally rather than centrally like a laminectomy. We go through a transpedicular approach without retracting the dural sac and the neural structures. We can approach the anterior elements and do our job. And therefore, if you look at literature today, it is very clear that modern spine surgery is superior to radiotherapy alone. Studies by Sundaresan and all show that the neurological improvement rate following surgery followed by radiotherapy is almost 70%. Another study by Regine et al. Showed that comparing radiotherapy against surgery plus radiotherapy, surgery plus radiotherapy had greater rates of ambulation recovery and maintenance and decreased use of narcotics. A study by Patchell which showed that the overwhelming evidence in favor of surgery, so much so that the study had to be stopped in the middle because people believed that you cannot let the patient suffer without surgery. They showed better urinary function, better motor outcomes, higher rate of return to ambulation, and patients were able to walk and live pain-free and mobile for much longer than if you just gave radiotherapy alone. Which finally brings us to the surgery part, which is what most of us as orthopedic surgeons or spine surgeons are interested in. And that is surgery. Now, surgery can have very gratifying outcomes and you can improve the life of this patient, but judicious selection of the patient is vital. And therefore, you have to ask yourself the questions: why, when, who, and what. Why should I operate? Well, you're operating because you want to improve quality of life. You don't want to cure the tumor. You can't. You are not able to treat the systemic disease. You are only trying to treat the pathology at that level in the spine. You are doing it to control pain, which you can do in 50 to 80% of the patients, and to improve the neurology, which so that even 30% of bedridden patients may improve. Pain is controlled by resecting the tumor, decompressing the nerve roots, and stabilizing pathological fractures. On the other hand, neurology can be improved by decompressing the neural structures and stabilizing the spine. Harrington, way back in the 1970s, gave a classification based on which he said you could decide about treatment. He divided spinal metastatic tumors into 5 types. The first one, there was no evidence of any neurologic deficit. Here he suggested that only chemo or radiotherapy is enough. If there was bone involvement without collapse, but no neurologic deficit, still the treatment would be chemo and radiotherapy. If the patient had a neurological involvement, but there was no vertebral involvement, the treatment would be radiation plus steroids. However, the moment there was a problem with pathological fracture of the vertebral body, instability, or a significant neurologic deficit, then the treatment moved on to surgery. So today, primarily surgery is done when the tumor we know is a radio-resistant type of tumor. That is, it is not sensitive to radiation, sarcomas, renal cell cancers, lung cancers, colon cancers. If there is a pathological fracture with retropulsed bone in the canal causing a neural compression, or if there is spinal instability, if there is a high-grade epidural tumor which is circumferentially compressing the dural sac, you must go in early. An occult primary tumor, you don't know where it is coming from, you want to find out. And of course, there are severe neurological symptoms. In all others, you would think of first giving radiation therapy or chemotherapy. However, if for any reason these treatments fail and you see that there is progression of neurologic symptoms, radiographic tumor progression or spinal instability, you must think of secondary surgery. The question is, should you do radiotherapy first or should you do surgery first? And there was a beautiful paper by Gogawala where he divided patients with malignant spinal cord compression into 3 groups: radiotherapy alone, radiotherapy followed by surgery, and surgery followed by radiotherapy. And they found that the wound complication rate, once you give that area a radiotherapy, the fibrous cells, the cells in that area become fibrotic, tissue becomes fibrotic. And that never changes. Even if you wait for 6 months or a year, it doesn't, it's lifelong. So therefore, once you have given radiotherapy, the chances of wound healing reduce. And it was found major wound complication rate was 3 times higher in the group that had radiation before the surgery. It was also found that the chances of neurological healing were poorer in patients who had radiotherapy first rather than if surgery was followed by radiotherapy. The next thing to consider, whom should you operate? Now you've decided why you want to operate, when you want to operate. You have to decide who is the patient who is perfect for operation. And the things to consider are the tumor and the prognosis of the tumor, the type of neurologic deficit, and the general condition of the patient. If the patient has a life expectancy which is less than 6 weeks or 2 months, then usually there is no point in doing. By the time he recovers from your surgery, the chances are that he will have died. So there is no point in subjecting this patient to an unnecessary operation. Also depends on the type of tumor. If the tumor is very chemosensitive or radiosensitive, like round cell tumors, Ewing's tumors, PNETs, multiple myeloma, lymphoma, these will respond beautifully to adjuvant therapy, and therefore you may not require to think of surgery on a patient like that. There are a number of scoring systems which have been outlined, starting with Tomita, then Tokuhashi, then modified Tokuhashi, then Bunger. There are a number of such scoring systems available. Traditionally, I have followed the Tokuhashi scoring system. It consists of 6 parts: Karnofsky performance status, which means what is the patient's ability to self-care. And based on that, the patient is given 0, 1, or 2 points. The number of extraspinal bony mates, that is bony mates outside of the spine. If there are none, you give the patient 2 points. 1 or 2, you give 1 point. 3 or more, no, 0 points. The number of vertebral mates, metastases to major internal organs, the primary site of tumor. Now it is known that patients with lung cancer or stomach cancer have a very poor prognosis, so they are given 0 points. kidney, liver, uterus are moderately good, and therefore they get an intermediate score. And thyroid, prostate, and breast have the best prognosis, and therefore they get the maximum points. It is also seen that patients who develop a neurologic deficit survive less than patients who do not. So if they have no deficit, they get 2 points, incomplete gets 1, and a complete gets 0 points. So the total score, when you compare everything as 2 points, 6 groups, 12 points is the maximum you can get. If the number of points is less than 5, then the chances that this patient will survive for more than 3 months is very poor. Patients with 6 to 8 points generally survive up to 1 year, and 9 or more usually have 1 year or more of survival. The next thing to look at is the neurologic deficit. If there is a complete cord lesion, which is of more than 24 hours duration, it is unlikely to recover, and operating on these patients does not make much sense. Rapidity of onset, like this girl whom I showed you as an example for biopsy, that girl had a rapid onset of paraplegia overnight. And if you look at the cord compression, it had not worsened and it was not severe. So there was a very good chance that there may be a tumor embolization of the spinal artery which had caused this paraplegia. And this type of a vascular compromise is unlikely to recover. Finally, what you look at is the severity of the deficit. If the deficit is mild, the chances of recovery are better. The more severe the deficit, the chances of recovery are not only poorer, but even if they do recover, the time taken to recover is so long that by that time the patient is ready to die. So what is the point of operating? The other thing you must look for is the general condition. How many comorbidities does the patient have? Is the patient in good physical health or is the patient fragile? And one factor which has been shown consistently to affect is the age of the patient. The more the age of the patient, the lesser is the chance of patient coming out of the surgery very well. Finally, it brings us to what should we actually do for these patients. Tomita helps us with this dilemma of what. Tomita declassified metastatic tumors into 2 types. Those which are within the bone, either vertebral body, pedicle, or lamina, these are called intracompartment, or those that are in the soft tissue or in the epidural space, these are called as extracompartment lesions. So he made 7 types of pathologies. Type 1, 2, or 3 were intraosseous lesions, which were intracompartmental, either involving one region or 2 regions within the spine. And extracompartmental were those which had either of the 1, 2, or 3, but now they were involving either the epidural space, the paravertebral space, or an adjacent vertebra. And type 7 were skip lesions. Based on this, Bunger from Sweden proposed the following rule. He said if the Tokuhashi score is 0 to 4, the life expectancy is less than 3 months. Irrespective of what the patient has, don't try to do too much for this patient. Just do a laminectomy or a laminectomy plus fixation. Don't try to do too aggressive a surgery. Now, if the Tokuhashi score is 5 to 8, the life expectancy is a little better. Irrespective of the Tomita score, you go and do a decompression and stabilization. And if the vertebral body is destroyed, you reconstruct it. Don't try to do major block surgery or anything. On the other hand, if the Tokuhashi score is 9 to 12, the life expectancy is more than 6 months. And then based on the Tomita type, the treatment is decided. If the Tomita type is 1 to 3, that is the lesion is completely intraosseous, then it's worthwhile taking the entire tumor out in one block and resecting the tumor and reconstructing the vertebra. So here you would think about marginal or wide margins. Type 4 to 6, where there is extracompartmental lesion, you go intra-lesional, you debulk the tumor, and then you reconstruct and stabilize the spine. And in type 7, which is where there are skip lesions, only decompression plus stabilization. This is the stage in which most of our Indian patients come to us, that they've already got skip lesions, multiple lesions, and then we are left with just stabilizing these patients for pain relief. When you talk about surgery, there are 5 steps. Step 1, if it's a vascular tumor, you need to embolize the vascular tumor. Then you think about excising the tumor in whichever method you feel comfortable. Step 3 is reconstruction of the defect that you have created because you've excised the tumor. Step 4 is restoration of the spinal stability. And finally, once you've done all this, 2 to 3 weeks later, you can think of giving this patient chemo or radiotherapy. So let's go stepwise. What is embolization? Embolization means that these tumors often have a lot of blood vessels which go into the tumor. If you can block the blood vessel to the tumor, then what you can do is reduce the blood supply to the tumor, causing reduction in intraoperative blood loss, maximizing tumor resection. You can reduce the mass effect, the tumor shrinks in size, it improves the cord decompression and alleviates the pain. Embolization is usually done by an interventional radiologist within 24 to 48 hours of the planned surgical procedure. Typically, they use either gel foam, which is temporary, where you must do the surgery in 12 to 24 hours, or they use beads or coils, PVC beads or coils to block the artery. In the good old days, embolization used to be of the segmental vessels. This was dangerous because it often related in cord infarct. Today, embolization, they are so beautifully done that it is called a super selective embolization. They can actually go and only block the vessel which is supplying the tumor and reduce the bleeding. You must be careful as a physician not to operate, or a surgeon not to operate immediately after. Wait for a few hours, because these patients may often develop a worsening of the neurology and then it will be blamed on you. So wait and check the patient's neurology before you go for the surgery. Also, administer steroids around the time of the embolization so that this problem of drop in neurology does not come in. There are certain tumors which are known to be hypervascular, where you must always embolize. These are renal cell cancers, thyroid cancers, neuroendocrine tumors, sarcomas and chordomas, or giant cell tumors, which is not a metastatic tumor. On the other hand, there are some MRI findings which suggest to you that this may be a hypervascular. Like you can see, there is a flow wide over here. There is intense enhancement on contrast images or intratumoral hemorrhage. These signs suggest that this may be a very vascular tumor, and these tumors need to be embolized. The second step in this is excision of the spinal tumor. That means removal of the tumor itself. And here we go back to our undergraduate experience knowledge of margins. Whenever you think of excising a tumor, you can excise it within the tumor, leaving gross macroscopic tumor in there. This is what is called as essentially a debulking of the tumor. The second type of margin is a marginal margin, where you go along the pseudocapsule, but you're still leaving satellite lesions outside of the tumor within the same vertebra. The third type of margin is a wide margin. It's an A-block excision outside the pseudocapsule, but in the spine, you're still leaving the spinal cord and the vessels and everything intact. And this involves much more effort. And the final type of margin is a radical margin, which is an A-block excision of the whole compartment. And sometimes in these cases, blood vessels, nerves, etc. have to be sacrificed. Here is a patient. This patient was operated by a spine colleague of mine in Bombay. He was a young 18-year-old boy who had a sarcoma on the foot, which had metastasized to the spine at D5-6. This patient was operated with an intralesional margin. You can see beautiful surgery, anterior transthoracic approach. And this patient had a stable fixation, patient improved, pain went down. But within 2 months, you can see the MRI on the right side, entire tumor had grown back. And in fact, the tumor had grown all along the incision that was taken previously. So when you do intralesional tumor excision and subsequently there is no adequate chemo or radiotherapy to protect you, then the tumor recurrence rates are as high as 40%, which can occur at the same or another level. And when the tumor grows back, it may result in loss of fixation, recurrent pain, and neurologic deficit. Total A-block spondylectomy is a surgery which is primarily done for a primary tumor of the spine and not for metastatic tumors. However, there are certain metastatic tumors where it is a solitary vertebral mets, there is a well-controlled systemic disease, then we do think of doing an A-block resection. The advantage is you're doing a near complete excision of the diseased tissue. There is minimal seeding locally, longer disease-free survival, and better pain control, better neurology, and better disease control. The limitations is it's a massive procedure, extensive blood loss, the huge risk of infection, instability, neural tears, neurologic deficit, and then it is technically demanding operation. The third step is reconstructing the defect. Now you have removed the tumor. 80% or 90% of the tumors involve the vertebral body. We also know that 80% of the loads of the spine are borne by the anterior column in the spine. And therefore, the anterior defect needs to be restored so as to allow load bearing. Now, the defect can be restored by using autografts or allografts. The problem with autografts is that subsequently the patient is going to get chemotherapy or radiotherapy. And therefore, this autograft often doesn't heal, it necroses, it becomes a dead sclerotic piece of bone over there. And therefore, patient may die before actually fusion occurs. In order to prevent this problem, in the 1960s and 70s, a lot of people started using PMMA, that is bone cement, along with some kind of a Steinman pin or coaxial in double lumen intercostal tubes, etc., were used, and the bone cement was used as a spacer. The advantage was cement is low cost. It provided immediate stability, so patient could be mobilized. So there were a lot of advantages of this. The disadvantage of using cement is sometimes cement can leak backwards into the canal, and that can cause either cord compression or even thermal injury to the spinal cord. The other disadvantage is the cement blocks may extrude, the cement may fracture. These are some of the problems. So the next stage came in with the use of interbody cages, either using cages which expand inside tube or things like the ham mesh in the center over here, which will act as a strut and help with restoring the defect. The next step, of course, is to restore you have now reconstructed the defect, but you need to restore the stability of the spine to prevent abnormal loading movement at the site of instability. That is neutralizing the entire forces acting over there. The problem here is that there is a contrary between doing too little and too much. If you do too little, the tumor may spread and you will land up in problems. If you do too much, the patient is going to have more morbidity, because often multiple adjacent vertebrae are involved, associated osteoporosis secondary to disease. Disease continues even after surgical extirpation. So here is an example, a solitary renal cell cancer involving only the anterior vertebra, where I have done an anterior approach, put screws above, below, and the patient did well. This was a lung cancer which had metastatized to multiple levels. She had severe pain. She was not able to sit up. We did a multi-level stabilization and from the back and helped the patient. Finally, sometimes you may require a combined anterior plus posterior approach. What about minimally invasive surgery in spinal tumors? The goal is to decrease morbidity and recovery time, initiate adjuvant treatment early. So there are a lot of new things which have come in. One is stereotactic radiosurgery. I'll be speaking a bit about it. Limited open decompression, tumor excision with endoscopy, microendoscopy is being done. In tumors which are causing pain and there is a possibility of collapse, one can do a vertebroplasty or a kyphoplasty for pain relief. Along with radiofrequency ablation, this is extremely helpful. In recent times, it has been discovered that in patients who have weak bones which are likely to collapse or which have already have pain because of the collapse, one can do a vertebroplasty or a kyphoplasty in order to provide pain relief. And therefore, in patients with painful pathological fractures without a neurologic deficit or significant canal extension of the tumor, one can think of doing a vertebroplasty. You can do it when you know how to identify an impending pathological fracture. And in patients who have already got paraplegia, they have nothing to lose, right? They still have a lot of pain, you can do vertebroplasty. How do you identify patients who have a possibility of collapse? It has been shown that if the costovertebral joint is involved, the tumor occupancy within the vertebral body is more than about 60% in the thoracic spine and 35 to 40% in the lumbar spine, then you could think of that this is probably an unstable and is likely to collapse. If the pedicle, one or both sides are destroyed and the patient has low BMD, these are all features which suggest the impending collapse. Here is a patient of mine. This was actually a multiple myeloma who had severe back pain, multiple level pathological fractures. He was not able to lie down in bed, had not slept in bed for 3 months because of the severe pain. We did a multiple level vertebroplasty. This patient went on to do extremely well and completely pain-free till she died. Finally, going to spinal radiosurgery. There are various types of radiotherapy which is given. Radiotherapy can be brachytherapy, where you insert a chip, and but this is used for tumors which are accessible and which are small in size. Then you have external beam radiotherapy, which can be given in a collimated manner, or it can be done by a stereotactic method. The advantage of the problem with typical radiotherapy is that when you give radiotherapy, you're not able to deliver the radiation dose precisely to the pathological tissue. It spreads along the adjacent tissue, also creating problems over there. The spinal cord has low tolerance to radiation, and therefore when you are trying to destroy the tumor, the spinal cord may be affected, and therefore you have to reduce the dose, which is below the optimum therapeutic level for that tumor. Stereotactic image guided delivery, you can actually deliver radiation precisely to the tumor tissue, reducing the amount of radiation to adjacent organs. And therefore, its advantages are percutaneous, it's minimum morbidity, excellent pain relief, long-term control, and treatment is often completed in a single sitting. So finally, after this long 45-minute lecture, I'm going to conclude. Why do we operate? We operate simply, we are not trying to cure the tumor. The goal of our treatment is alleviation of pain, improving function by preserving neurology. When do we operate? When do we need to do surgery? When can radiotherapy or chemotherapy not be given? If they are radio-resistant tumors, if patient has a significant neurologic deficit, if there are pathological fractures and instability. Who should you operate on? When the anticipated survival time is more than 3 months. And what gives us a guidance? The patient's medical comorbidities, the age of the patient, the type of neurologic deficit, the type of primary tumor are all features which help us to decide which one you want to operate on. And when you operate today, you must remember that there is no role for decompression alone, except in possibly metastasis into purely epidural metastasis or intradural metastasis. If there is any involvement of the vertebra or pedicle, it is safer to stabilize these patients in the long run. So my final message to all of you is the goal as a spine surgeon when you treat these patients is to be godly. You want to be able to help this patient, but don't think you're God and you can cure everybody. I think in my practice over the last 20 years, I have seen more than 400 to 500 metastatic tumors, and I must have operated only about 100, 150. So majority of them you are refusing because they don't fulfill the criteria for surgery. Thank you. So I'll stop here. I will take questions from the audience and then we'll move on to the case presentations.
Thank you, Dr. Gautam. Thank you so much for wonderfully elaborating exactly the principles of tumor surgery. We already have plenty of questions. So let me call upon all our panelists on there. And apart from the panelists, we have with us senior spine surgeons from Bombay Spine Society, Dr. Mihir Bapat and Dr. Arvind Kulkarni also. Thank you all of you for joining us. The first question here, Dr. Gautam, I would like to pose across from the delegates on behalf of them is, we yesterday have been discussing about cases where patients come to us with symptoms, mechanical symptoms, non-neurological symptoms, with a lesion in the spine. Is it mandatory to do PET CT scans and detailed tumor markers in them, or we should do a biopsy first and then think about PET CT scan? And what is your take on that?
No, I think, as I said, when I was going through the investigative cascade, I suggested that these are interchangeable. Ideally, you should always do all non-invasive tests before you do invasive tests. So principally, you should do biopsy after that. But the honest answer is that PET scan is a very, very expensive test. And often, if it's a solitary problem, you're not even sure this is a tumor, then it's worthwhile doing the biopsy. At least the biopsy does not alter the outcome of a PET scan. It may alter the outcome of an MRI scan, but it doesn't alter the outcome of a PET scan.
I think yes.
So
I think
you can go ahead.
Message very clearly taken. Biopsy is a mandatory thing. You have to do it. PET CT scan has dual role to play. Not only it gives you an idea about whether you're dealing with a single lesion or any other peripheral better accessible lesion is also present. And also the second thing it helps you is to stage the thing, because sometimes you may see multiple metastases and instead of one, and that will completely change the whole scenario of the situation. So in those situations, PET CT scan really comes handy. But at the same time, like Dr. Gautam mentioned, PET CT scans are very costly. They cannot be the primary investigation for you. And since they are not the supplement to biopsy, they cannot subside the biopsy's importance. And that is why biopsy is important, should be done as the earliest as possible. And ideally should be done from the most accessible side rather than depending only on spine. And to get the most accessible side, doing a detailed investigation, both clinical and radiological, is very important. Let me catch Dr. Arvind Kulkarni. Dr. Kulkarni, you're there. Can you unmute your thing, your speaker there? So in this situation, you suspect that there is a patient with high index of suspicion about tumor, and you get a negative biopsy. What do you do in that situation? Do you now at this point start thinking, or you jump for a second biopsy as well?
Yeah. So I usually make sure that that I don't get a negative biopsy. I try to send it to the best person possible. And many of the times, especially when it comes to tumor, I've got positive reports. But in a situation like this, I mean, this is prior to doing a PET scan or after doing a PET scan?
No. So you have done your PET scan. There is a single lesion seen there, and it's an atypical radiology. It's very common to see atypical radiology, and your biopsy turns out negative.
Yeah. So I'll discuss with this radiologist whom I sent this sample to, and ask him what would have gone wrong. And if he is positive of getting another good sample and getting results in quick time, so then I'll probably push the patient to get a second biopsy done. And if he is not confident, then I would go in. I mean, I would go in and operate. This is solitary beds. I'll do a posterior fixation first, and yeah.
Right. So I think Arvind is absolutely right, Vishal. I would like to add to this that biopsy is not simply putting a needle into the bone. You have to plan your biopsy. You have to see on the MRI, CT scan, whatever investigation you've done, what is the location of the tumor, and your needle should go in that direction. There is no point in doing a biopsy. Often what you see is a lot of hyperintensity signal within the bone marrow. And if you put your needle in that region,
so Gautam,
then you will often find inflammation. So therefore, planning the biopsy is very important. And that is another reason why I am keen that we as spine surgeons should do the biopsy than referring it to anybody else.
Right. I think message is very clearly.
Two more points. Just two more
Priyank,
points to this.
Priyank,
to what Gautam has said. A PET guided biopsy can be done. So you can study your PET scan, and that will show you the place where there's maximum uptake. You can tell your CT guys to pick up the spot from there. The other option is to do a CM guided biopsy, and at that same time send the sample across for a frozen section. As long as something comes up on the frozen section, you're okay. If not, you can keep doing the biopsy till you get something on it.
So Priyank, that is not a great idea, the second part. And that is because what happens is that majority of these places when you are doing a spinal tumor, you are getting a bony lesion. Hello? Yeah, can you hear me? Yeah, the problem, Priyank, with that idea is that we are not dealing with soft tissue. We are dealing with bone. And bone is almost impossible to get a good frozen on because it requires decalcification. So therefore, second part, the first part I would agree with, that you could do a PET guided biopsy, or as Abhay has done very well, that is Dr. Abhay Nene, is that he has worked with his radiologists and trained them as to what type of biopsy he wants. And if you can do that, and if you can work with them and you can train them to do core biopsies, then nothing like it. Then ideally a CT guided biopsy is the best way of doing a biopsy.
Right. I think message is clearly taken that biopsies can be done in various manners, and it doesn't mean just poking in a needle there, getting a good chunk of sample from the affected vertebrae and sending it with proper sampling of the sample, very, very important. The other thing that is very important nowadays that is available is PET CT guided biopsy. That's something that we all must remember. Another question that was coming across, Dr. Mihir. Dr. Mihir, are you there?
Yes.
There's a question coming up that if we have to plan a biopsy, is there a specific needle trajectory that one should take in view of a subsequent surgery coming up? Like if you're planning a en bloc resection later in a solitary case, you are worried about the needle trajectory. Is there a specific thing that you should plan, or you should talk to your radiologist who's doing biopsy for you?
Yes, I think so, because if you are planning a total en bloc resection in either a solitary met or in case of a primary tumor, your biopsy has to be included within the area of skin resection. So doing a biopsies anteriorly should be clearly avoided. Your biopsy tracks have to be posterior, and they have to be as close to the midline as possible. So you have to work in conjunction with your radiologist and plan a tract which can be excised without much of skin loss, as you are going to do that, do the surgery posteriorly.
Right.
Am I heard?
Yeah, very clearly, Mir. Can I add to your statement?
Yes.
Hello?
Yes, please.
Yeah, can I add to your statement, Mir, that unfortunately in the spine, to be able to resect that biopsy tract with your en bloc resection is almost impossible, because you can't really go more medial than 1.5 centimeters away from the midline, isn't it?
Right.
If you are going to do a biopsy. So all this is very, very valid for a general surgical tumor, but not necessarily for a spine tumor. We are not able to do that. We have to accept that deficiency to an extent. Vishal, I would like to start with the cases now, and we can keep on with the questions during the cases.
Yeah, we have few more questions which are pertinent to the topic that is happening around. Can we just take few more questions before we go on to the cases coming up?
Okay.
So another question that was here is that there are situations where you see a malignancy, but a malignancy or a metastasis of unknown primary with a vertebral body which is intact. Where
Hello. Vishal, you're stuck.
Hello.
Hello. I think Vishal is stuck.
Yeah, I can hear Mir very well, but I can't hear Vishal.
No, Vishal is stuck. We can proceed with the cases, Gautam.
Gautam.
Arvind, I'm listening.
Yeah, just wanted to check, see the amount of cement that one can inject, in one sitting. I tried to find out literature because I had a case of pulmonary embolism. How much can you inject in one sitting?
So what is recommended is that minimum 2 cc is required for pain relief. There is some
you
studies.
showed in case multiple levels, no? So I.
Oh yeah. Those were done in 2 levels, 2 sittings.
2 sittings.
Yeah. So I did 3 levels in one sitting and 3 levels in another sitting. Pulmonary embolism has not got to do with the amount of cement you inject overall. It has to do with the amount of cement you inject per vertebra. So ideally per vertebra you should inject anywhere between 2 to 6 cc. The minimum requirement is 2 cc. Ideally it should be more than 4 cc, and after 4 cc you should do as minimum as possible, because by adding more cement you are not giving more pain relief. Even 2 to 3 cc gives you as much pain relief as a more cement. So more cement is not better, and that is why I have problems with kyphoplasty. All right, let's move on to this case, guys. This is a 67-year-old lady who came with pain in the neck for 15 days. No radicular complaints, no neurological symptoms in the upper and lower limb, no trauma, no fever, weight loss, anorexia. She just had tenderness in the midline at around the mid-cervical spine. Flexion was painful, neurology was normal, general examination was not significant. This was her X-ray picture. Shibli, are you there in the audience? Shibli? Acha, Shibli. Okay, Priyank, what would you do? What do you see on the X-ray?
Hello.
Priyank. Shibli, what do you think? X-ray?
X-ray, there seems to be destruction anteriorly and sort of straightening of the spine. Ideally, MRI is needed in this in order to decide.
Sure. So there is a pathological fracture of the C4 vertebral body. You can see a collapse of the vertebral body. There is nothing else which you can see specifically on the cervical spine X-ray. So how should we proceed here? Blood tests, MRI scans. Shibli wants an MRI scan straight off, so I'm giving it to him. Here you are, Shibli. This is an MRI scan. You can see a pathological, almost like a codfish vertebra at C4. There is no significant spinal cord compression. There is no evidence of any abscess anteriorly, posteriorly, nothing. In fact, I do not even see any hyperintensity signals within the vertebral body. So what do you think is going on and what should we do now? Is this osteoporosis? Is this a tumor? Is this an infection? What is the cause of this?
Looking at the MRI, both the disc superior and inferior looks pretty healthy. Just the destruction of the bone and not much of neural compression and soft tissue anteriorly can be seen. So depending on the symptoms, like if the patient has a significant pain, patient can be advised, PET scan, depending upon his counseling, either the PET scan primary to detect the primary or directly go for anterior surgery in order to stabilize, to reduce the pain, and simultaneously we can get the sample and get the diagnosis also.
Right. So Shibli, you are suggesting that there is no involvement of the disc space. There is no evidence of any lesion in the subligamentous area anteriorly or posteriorly. So this probably is not an infection, but you're not sure as to the primary diagnosis. Mir, any thoughts? How should we proceed here at this stage?
In this case, I think a PET scan would precede a biopsy because biopsy is relatively difficult to execute for most radiologists in the cervical spine. So trying to see whether there's any other lesion elsewhere would precede my biopsy first, and then at the same time try to get a biopsy out of this lesion.
Gautam, hi,
hi, Samir, how are you? Samir, come.
Hi, sorry, I just finished my afternoon nap. Sorry.
Bolo, what do you think? You saw the story from the beginning.
Yeah. No, I've been there for some time.
What do you think we should do here?
No, I think the first important thing, this patient has only pain and no neurology, so we have our time to get a good diagnosis. And given that many patients don't need any surgery and just medication, so I think the rather than going for a PET scan, which of course is good, I think the first thing you can do is just do a simple ESR and a electrophoresis, because with this sort of picture, a myeloma is very likely. And I didn't get whether it's female or male, but you can do the other tumor markers as well. I mean, so depending on whether they're male or female, there would be different tumor markers. We can do that. And also important would be to take a history. Sometimes, patients don't come up with a history, but if you take a history from them and their relatives, for all you know, she may have had a CA cervix earlier because of which she had a hysterectomy, or a CA breast or a breast lump. And sometimes they don't tell the patients, and they don't tell the doctor either because they think it's not important. So going backwards, I think history, then doing a very basic checkup for the first most common malignancies. So a blood test for ESR and electrophoresis, simple thing like a chest X-ray, USG thyroid, CT abdopelvis, which will tell us, give us some idea of screening out the common malignancies, may give us an answer. And of course, the next step then becomes a PET after that.
Right. Lovely. Thank you very much, Samir, for chipping in. So we did do some basic blood tests. The hemoglobin was 9.5. The WBC count was not really helpful. ESR was elevated. CRP was elevated. Rest of the blood tests were normal, but the calcium was also normal. Alkaline phosphatase was slightly elevated. We had done a protein electrophoresis, but at that point, it had not yet come. So what should we do next? I think Samir has already told us that he would like to wait and do a protein electrophoresis. We've also the possibility of doing a PET scan subsequently, or as Mihir suggested, a PET scan at this stage. Shibli was worried about the possibility of pain, a problem of pain, and therefore he wanted to do a surgery with an excisional biopsy. Well, gray hair or absent hair always helps. As Samir suggested, the protein electrophoresis showed an M band. The diagnosis, in fact, was a multiple myeloma. And this patient had no neural compression. no mechanical instability. The tumor was sensitive. We know myeloma is sensitive to chemo and radiotherapy. And there was limited systemic disease. The patient was otherwise healthy and fit. And therefore, she was subjected to chemotherapy plus radiotherapy locally. And she went on to live for another 6 years before she went off. So to conclude, diagnosis of pathology is mandatory before any surgery is thought of. For solitary vertebral collapse, you must think of doing an MRI in order to see what is bone marrow changes are there locally. Do blood tests, especially as Samir said, one of the easiest ones to diagnose on bloods is a multiple myeloma, so get it done. If it still doesn't give you anything, then the next stage would be a CT PET scan and finally a biopsy. As Mir said, biopsy in this region is very difficult. C4, you can't go for posteriorly, the lesion is anteriorly, so it's difficult to approach anteriorly. So therefore, sometimes if things don't work out after a CT PET, you may even do an excisional biopsy as should be suggested. In the absence of any mechanical instability or significant spinal cord compression, chemotherapy and radiotherapy is the preferred treatment in this patient with multiple myeloma. Let's move to the next case.
Dr. Gautam, before you move on to another case scenario, let me just... Yeah. So let me just bring a very similar case scenario, because this was cervical spine where we were thinking, and it's a preferably a favorable kind of pathology. However, if same situation happens to us in a thoracolumbar spine or in a lumbar spine, which is a commoner scenario than this, where a lesion, an independent lesion with a structurally mildly compromised mechanical integrity, but no neurology, say for example, a L2 lesion and patient in terrible pain, would you still continue and give only chemo for these patients, or there is a role of vertebroplasty, or there is a role of impending stabilization for them? Like a, do we know that this is not going to progress on radio and chemo?
So as you saw in my lecture, that we don't know that anything is always going to respond to a chemo radio. But if there are symptoms of mechanical instability and you see radiologically on CT scan or MRI scan, significant involvement of the vertebral body in circumference as well as of the pedicle, then you know that there is a possibility of an impending fracture. In these patients, considering a vertebroplasty or a minimally invasive pedicular screw fixation would be definitely something which would be worthwhile going for.
I think there are papers which have mentioned about risk factors and probability of vertebral body collapse in such lesions. So there are some risk factors which involves more than 60% of vertebral body involvement of one pedicle or more. All these things have known to show that the high propensity of pathological fracture in these patients which have not had a collapse in as of now. So any thought on that? Like how do we know?
Yeah, I think I have a thought on it. I think
I've just shared an article on risk factors and probability also.
Right. So without having read that article, just on the basis of the experience, you will be surprised how many patients with really bad looking X-rays and MRIs do get complete relief of pain. And the reason is that the pain, a large part of the pain is disease pain rather than a mechanical pain. And my choice would always be treat the disease first and then the mechanical part later on. And if you give chemo and then after that even radiation, most of them settle. There are very few patients who continue to have pain and who then you think need a surgery. And I can tell you one thing, those who continue to have pain even after surgery, they still continue to crib of pain. So I think most patients with myelomas do get better with just radio. So I'm not talking about the neurological involvement. Even neurological involvement is maybe there'll be a case later on, but even neurological involvement, we have to admit that chemotherapy and radiotherapy works very, very well for soft tissue compression with myeloma.
I and Samir have a patient. Samir may be remembering this patient who has a L5 big lesion with multiple myeloma who is on chemotherapy.
Huh? The lady who went to America?
No, not that lady. There's one gentleman who had a L5 lesion alone.
Yeah. Okay. Right.
Guys, what I feel is that
so he did totally well with just chemotherapy. Gentleman who he's talking about, the gentleman who is talking about, if you saw his X-ray, you will get a fright. If you saw his CT, you will get a fright of your life. But this guy chose conservative treatment. Unless and until Arvind or Anshu operated him, I think he did okay with just conservative.
Dr. Arvind, Dr. Sameer, Dr. Arvind, Dr. Gautam, I'd like to draw your attention to this, that you may be talking about sporadic experiences on one particular case, whereas what I am talking about is literature on thousands of cases based on these scoring systems that are mentioned in literature. And there is a widespread use of these scoring systems, not only by me, but also by a lot of individuals around the country, saying that there are specific risk factors, prognostic markers, and there are objective criteria to say that this fracture is going, this body is going to collapse with whatever treatment you give, and there is a role of preemptive fixation. What I want to understand from
we
you
shall
as
already, that was already mentioned in the lecture. I gave you chance predicting factors for possibility of impending collapse involve the BMD of the patient, the amount of tumor occupancy of the vertebral body, the involvement of the costovertebral joint, the involvement or destruction of the pedicles. These all gets point, and this is part of a scoring system which helps you to decide whether this is an impending collapse or not. And therefore, in patients with impending collapse, you may consider surgery. Having said that, if you have seen patients with multiple myelomas of the sacrum, they are huge myelomas which have completely destroyed the entire structure of the sacrum. Only the shell is left. But if when they are treated with chemotherapy and radiotherapy, they often the whole sacrum reforms. And that is what Sameer is trying to tell you. He is not trying to trivialize the fact that there is you don't need preemptive fixation or preemptive vertebroplasty. He is saying that there are cases which have been observed where radiotherapy and chemotherapy when given tends to absorb the tumor, and that the entire bony structure seems to regrow in these cases. So we have to take that into thought also. One does not decide. And if you know how studies are done throughout the world, then you know how these studies are published also, and that often anecdotal personal experience is sometimes better than these studies.
Yeah, I think at this point there are so many guys who are following you all, and I think a message has to be passed on, and the message has been very clearly given by all of you. And I would just like to summarize this, that there are ways and means to predict a preemptive or a imminent instability for a vertebral body in metastatic situation. You can pick these patients early, and a preemptive stabilization of these patients is recommended. Yeah, maybe we can just jump on to the second case now.
Okay, let's move to the second case. This is a 74-year-old male, hypertensive, but otherwise fit and active. The patient had a renal cell cancer for which he had a nephrectomy done 2 years ago. Presently, he has severe pain in the neck for the past 15 days. Severe right-sided C5 radicular pain, weakness and numbness in the right upper limb. On examination, there is tenderness in the midline of the neck. Movements are painful and restricted. There is C5 and C6 right side grade 3 power and hyposthesia. You can see on the CT scan that the C6 is completely lost, destroyed. An MRI scan was done, and this was the picture. There was a destruction of the bone, a soft tissue mass which was compressing the cord, and there was some amount of instability. As you can see, the C5 vertebra seems to have slightly translated above below. CT PET scan revealed a solitary lesion at C6. There were no other lesions at that stage. Now, how should we proceed? Should we do a CT guided biopsy, chemotherapy, radiotherapy, surgery? We have Kedar Devgaonkar here. Kedar, where are you? Can you get down?
Yes, I'm here. Can you hear me?
So, Kedar, what would you like to do? CT guided biopsy, chemo, radio, surgery, what?
So, given his age and on the MRI, I can see some involvement of the vertebra above the fractured vertebra as well. So, I don't think I'm thinking in terms of any en bloc here, although you say it is a solitary metastasis. Would like to do a CT guided biopsy just to confirm. And then in this age group, I think palliation would be my guiding principle. So in terms of that, we can do a decompression and fixation from the front, and depending on what the picture shows, from posterior as well if needed. No, not for en bloc.
We have got a very aggressive, if not aggressive, let's not say, but a very advanced or technically advanced surgeon now with us, Dr. Abhijit Pawar. Abhijit, what is this about not doing arm block just because patient is 74? Why don't you want to do the arm block? What would you do in this patient?
this patient has history of renal cell carcinoma. So this is likely to be a mets from a renal cell carcinoma. I would not do a CT guide biopsy because RCC are very vascular tumors. Looking at the MRI, he has a significant compression at in the cervical spine. If you don't treat this patient on time, he might end up getting paraplegic. So I would embolize this tumor, decompress and stabilize this patient to avoid a paralysis.
Front and back, what?
I would do both, front and back.
Anterior, posterior, combined.
Yes.
Combined.
I would embolize
I think that's, yeah. Let's move on to Gururaj Sand.
I think before you move on, it's very unfair to ask for opinions unless you show all the imaging. Because if
I completely agree. And in fact,
if you don't see a CT, if you don't see what's happening to the posterior elements, why are we planning on all we can, posterior elements, we don't know. Where are the axial cuts? Okay. So I think that let's not get you can also manage this with only anterior. You don't have to do anterior posterior. But the principle remains the same. The biggest principle, and I'm glad that he pointed out that renal cell carcinoma is horrible and you have to embolize it. So embolization is a must. Anybody who jumps into this without embolization is really going to land up with a bloodbath. And you need to go from the front and decompress, etc., and then reconstruct. And you can use cement, cage, whatever you want, plate, long plate. And then based on what stability you got and whether the posterior elements are involved, you can decide whether you want to do posterior as well. So this is a purely palliative procedure. It is not a curative procedure. It is meant to tide over the whatever years are remaining for this patient. And for renal cell carcinoma has no adjuvants whatsoever. So therefore surgery is the only choice.
So we've got the Bombay opinion from Dr. Dalvi and Dr. Pawar here and Dr. Kedar. We are going to go to Delhi and we are going to get Gururaj Sand Gopinath to tell us what they do for these kind of tumors in Delhi. Is it any different or is it the same?
I agree with Abhijit that embolization first. But then we can, if we see that there is an inferior end plate destruction also of C5. So I think in this patient, we need both anterior and posterior because if we take out the C6 and put some cage there, it is going to sink into C5. So we need to do both anterior and posterior.
Right. So I think at the very least, what everybody has agreed on is that it is a solitary metastasis. There is spinal cord compression, there is pain and instability. The patient, although 74, is healthy and fit, and it's a chemo and radio resistant tumor or metastatic renal cell, and therefore surgery is indicated. The Tokuhashi score is good, survival is more than 6 months, so one should think of surgery. An arm block at 74 may be too much, and therefore I would agree with Kedar that doing an anterior reconstruction. So here is what we did. We did an embolization as suggested by everybody, and you could see the tumor blush, which disappeared after the embolization. And we did an anterior plus posterior. We did a C5, C6 corpectomy, and then stabilized it from the back also. Patient went on to do very well. So to conclude, renal cell cancer has a chemosensitive, resistant and radio-resistant tumor. But if there is significant spinal cord compression plus instability in a healthy active patient with well-controlled systemic disease, then it merits surgery, especially if the tumor is radio-resistant. The renal cell cancers are always hypervascular and you must always embolize these patients. Any comments from anybody before I go on to next case? So Vishal, you want to lead
one quick comment. I think unblock resection is possible only when there is no epidural spread. The moment you have seen that the tumor has already gone into epidural spread from one compartment to other compartment, I don't think unblock is possible. Even if this patient was young, you wouldn't have been able to do it. It would still have been a wide resection at the max, not an unblock possible at all.
Gautam.
Very, I think, very valid point, Vishal. A lot of people don't realize that most of the times we see patients in India who are extra compartmental, extra lesional outside the bone. And the moment that is there, arm block is never possible. But at some point, you have to go into the tumor in order to excise the vertebra. So complete arm block is not possible. Yes, Arvind, you wanted to say something.
Yeah. So knowing that she's not going to live for more than 6 months, was there a need to go posterior?
He is going to live for more than 6 months. His Tokuhashi score was more than 9.
So anyway, so I would like to draw your attention here is these scoring systems have their own flaws, and there are multiple studies with inter-observer variation studied and validated that all these scoring systems underestimate the survival of the patient despite the best scoring systems available in the literature. They all underestimate. I have just shared one article, Prediction Accuracy of Common Prognostic Markers. It's a study that has come up with the largest tumor group on 11,000 patients where various scoring systems have been compared. If you all can download this article, Prediction Accuracy of Common Prognostic Markers in Tumors, it mentions that though in one of Tokuhashi scoring system says that it is 7 month survival, 8 month survival, but the actual survival has gone in all the way up to 24 months also. And that is why most scoring systems only underestimate the survival, and they are not the only thing that you should rely upon while taking a surgical decision.
Right. Let's move on to the next case and get some more people involved now that I've seen who else is there. 33-year-old lady. She had a soft tissue sarcoma over the forearm. It was operated, a wide excision was done. 12 months later, she had another lesion which involved the left 10th rib. At that time, the investigation showed that liver and spine were also involved. She had a wide excision done of the 10th rib, and she had 6 cycles chemo taken, following which the lesion seemed settled down. 6 months thereafter, she presented to me with pain in the mid-back, severe pain radiating along the chest wall. There was tenderness of D7 feet. Movements were painful. Power was normal in both the spasticity, brisk reflexes, and planters were upgoing. This was her MRI picture. A biopsy was done by somebody else before the patient came to me, and it showed that it was a metastasis from the sarcoma originally. This was the MRI picture. You can see involvement of the posterior half of the D7 vertebra with epidural spread. Both pedicles were involved. There was compression of the spinal cord in this patient. What are our treatment options here? Should we think this is a sarcoma which has metastasized to multiple places? In the past, it has responded elsewhere with chemotherapy. How should we go about treating this? This was referred to me by the medical oncologist, saying that they wanted something done for this. So this is a chemotherapy. Should we think of radiotherapy in this patient? Should we think of surgery? She had early neurologic deficit. Radiotherapy followed by surgery, surgery followed by radiotherapy, or something else. We have Amit Sharma with us on the line. Amit, can you come online and talk to us? Amit?
Hi, sir.
Hi, Amit.
Hi, sir. How are you?
Fine, fine. How are you, Amit? We have seen the case, I hope.
Yes, sir. I'm there.
So what do you think? How should we think about this patient?
Sir, I think the diagnosis is certain that the patient has a history of sarcoma, and the current biopsy also shows the same. So I don't think that there is any confusion about the biopsy. Patient is neurologically intact. So
early neurology.
There is brisk reflexes,
okay.
Spasticity, some difficulty walking, but power is normal.
To be true, I'm not too certain about the chemo radio sensitivity of the tumor, but if it is, then I think there is no real rush to go for the surgery because it looks biomechanically not unstable. So I think if the tumor is chemo radio sensitive, then I would like to go for that before subjecting the patient for any kind of surgery.
Kishore, what would you do? Kishore, have you heard the whole story?
Yeah. I would definitely go for a surgery followed by radiotherapy.
Right.
I think we also have RK from Muscat, who's also a very prominent tumor surgeon. Can we have RK? RK, are you there? RK, can you hear us? Ranjit Kumar?
Hi, Ranjit, are you there? No. Ranjit Unni Krishnan is there. Ranjit, what do you do for this in Kerala?
Sir, I think the principles are same all over the world. I think should we change? I think the same pattern.
So what would you think? Would you think of chemo radio here, or should you go for surgery?
Sir, primarily, we have I've gone over to look at the norms and the sins grading, because that's been more
clear regarding the prognosis, and what the point which Dr. Arvind Kulkarni mentioned first is 6 months. It is 6 months is patient going to live. Should we do a surgery? So I think all these guidelines say if the patient is going to live for more than 3 months, we should do anything that will keep the patient pain-free and walking. So
what I would like to highlight for all delegates here, everyone who's participating and listening on Ortho TV, YouTube and Facebook, if you see all the panelists, every senior member in the group is only looking at one thing. The first and foremost thing is diagnosis. And the second most important thing after having established a diagnosis.
Hello. So I think Vishal has got cut off again. Anyway, so this was the situation. We can get Mir involved here. Mir, what do you think?
Yeah, so I think it's a sarcoma, so it's going to be chemo and radio resistant. So the only option is going to be surgery. The earlier the surgery is done, the better, because you can maintain function, but you can't restore function once it is less than grade 3. So the prognosis gets poorer and poorer, and that is why early debulking is probably the better option. The patient is general condition-wise better, and also surgery-wise, he has a better chance.
Right. So, Samir, final words before I show what is going to be done. Samir?
I agree with all of them.
All right. So, Samir is there. Abhay is there. Abhay? Well,
Dr.
yeah, somebody wants to say something. Guru, yeah, tell me.
Guru, yeah. Just I wanted to ask, like, how many of us want to do a en bloc here?
How many people would do an arm block over here?
No, this is not amenable to arm block.
Yeah, no.
It is already a marginal. What he's saying is a wide margin, marginal margin, not a complete arm block.
The thing is
surgical exercise. This is a surgical exercise here.
So arm block here, Guru, does not make much sense, because this patient already has had metastasis at multiple places. It's not a well-controlled disease per se.
Yeah.
And even over here, there is paravertebral as well as epidural spread. So you are doing surgery to stabilize and decompress the tumor. So maybe an arm block may not be the best option. Would you do an arm block, Guru, over here?
No, what I mean is, like, want to remove as much as possible the whole tumor.
So would you do a vertebrectomy in this patient?
Yes, because want to decrease the local recurrence also.
So what would be your surgical plan? Anterior, posterior, combined, what would you do?
No, I would do everything for posterior.
So posteriorly decompress from transpedicular approach, you go and do a vertebrectomy, reconstruct and stabilize. Yes. Is that what you would do? Here you just mentioned debulking. So what would be your plan be? Would it be different? Or you would just do a posterior stabilization and transpedicular decompression?
See, the aim here is to free the spinal cord for this moment in time. And really the prognosis of a sort of a complete vertebrectomy versus maximal debulking in this particular scenario is going to be the same. So the minimum early surgery which ensures good decompression is the correct surgery.
All right. So here is what I am going to tell you what I thought. I thought that this patient was a sarcoma which was chemo resistant and radio resistant. I thought that this patient has within the last 18 months developed multiple lesions at multiple places. So it's not well controlled and this patient is going to die in months. And therefore, I agreed with Mir when he said that you should do a debulking operation and decompress the cord and stabilize the spine. So I did a transpedicular decompression with posterior instrumented fusion in this patient. Patient's neurologically improved, she became pain-free and she went home very happy. 12 months later, she came back to me with paraparesis. Yeah, Mir, you had to say something. Tell me.
Yeah, this is what I think Gautam, what we are missing out here is that once we get a debulking done, we have to really stage this sarcoma all over again. If it's a low-grade sarcoma, though it is metastatic, the prognosis of this patient increases. So if it comes out to be a low-grade sarcoma, you have a reason that you go in again and try to get the whole tumor out as much as possible, allowing him a little better prognosis. But if it turns out to be a high-grade sarcoma, then this patient has a very poor prognosis.
Right. So that's essentially what happened. I think, yeah, Guru, you wanted to say something. Tell me.
we had a biopsy already done from the other site. So it would have already told that it is a low grade or a high grade sarcoma.
It's a low grade tumor, essentially.
So it's a low grade tumor.
If it
she had survived for 18 months. That's why she has survived for 18 months after the primary metastasis.
So if it was a low grade sarcoma, then we should have done a complete vertebrectomy.
In the sense
that's where my mistake was, that I did this and the tumor continued to grow in the vertebral body. Chemo and radiotherapy, which was given following the surgery, did not work. She went on to develop a slight pathological collapse of the vertebra and posterior extension of the tumor, and she presented again with paraparesis. The question was what to do now, and I went in again. I did a vertebrectomy this time, reconstructed anteriorly with cage and bone cement within the cage. Again, her paraparesis completely improved. She became normal. She went home. She did very well. 3 months later, again she came back. Again, she now had a circumferential posterior tumor at the back. She had again got a neurologic deficit. She was again yet ready for me to do a surgery. I did do it. Again, she recovered neurologically, but eventually she got a recurrence and became paraplegic. Even after becoming paraplegic, she survived for another 12 months. So the answer here is that every time we cannot be right. So it's all very okay in a group meeting like this that I chhati thok ke main bolta hu ki I do this, everything is right. But sometimes all of us make very wrong decisions. So probably what Guru said was probably the right way. We should have debulked, but the debulking should have involved a excision of the vertebral body. Yes, tell me.
No, Gautam, can I intervene here?
Yeah, bolo.
I don't think that doing a vertebrectomy or a debulking would change the prognosis of this patient.
Yes. But would she have lived whatever life she had near? Would I have regretted for the rest of her life, for the remaining time, that I could have at least, I know I cannot have changed her survival, but could I have prevented her from developing paralysis?
I don't think so. Even
I think Dr. Mihir, Dr. Mihir, Dr. Gautam, the message out of this case, this may be one of the case, but for a larger interest of 1,000+ people who are watching this scenario, the message is very clear. Having established a diagnosis, having understood the survival of this patient, there are various objective scoring systems available to evaluate, scoring system which take into consideration not only the type of tumor, the number of metastases, the age of the patient, whether there is lung mets or not, whether it's a chemo-resistant or a radio-resistant tumor, all these factors, and then of course the paraplegia, the neurological status of the patient, the general well-being of the patient, multiple variables.
Can I interrupt you here? Now, if you see this patient, for example, this patient had come to us after having a soft tissue sarcoma of the forearm and a soft tissue sarcoma of the ribs, which had been treated with chemo and radiotherapy, and lesions in the liver and all had regressed. So now when she came back to me first off with a vertebral body lesion, which was involving the canal and very mild neurology, where she was still walking, how would you grade it as? Would you say this is a soft tissue tumor which is radio or chemo resistant and has had multiple metastases in the past? Or would you say that at the current time when I saw her, she had no metastasis? So actually you should be given grade 2, 2 points on the number of metastases. So here the problem is that it is a gray zone in terms of trying to quantitate survival. Should you quantitate how many metastases the patient had previously had or currently had?
Sir, one of a case will not change the course of overall prognosis that is applicable to 90% of tumors. And on this broad platform, I think though you have a case scenario which can be an example of one of its kind, however, the general principles cannot be disrupted based on this case scenario. And the general principles are very well laid down. I am sure you also follow them in your practice. You have taken validation of Tokuhashi scoring in your system. What I'm trying to convey is that before we plan a surgical measure in any of the patient, we, like Dr. Gautam, Dr. Sameer, Dr. Mihir, for all the delegates, please understand these are all experts. They have been operating on tumors for very, very long time. Their clinical acumen is guiding them apart from the objective scoring system. For all the other lesser mortals like us, I think depending on scoring systems and really relying upon the scoring system is something that will come very handy to you. And once you have done plenty of those scoring systems, only then will you be able to validate your own outcomes. And cases like this will surely prompt up to you where your clinical acumen will have to be deciding factor rather than only the objective scoring system. And like I just mentioned, there is a inter-observer variability and underestimation of survival by these scoring systems. And that is why more than one scoring systems are available. None of them is foolproof. Every scoring system has its own flaws. Dr. Gautam has just showed one of his case where the flaw has become so very apparent. But the emphasis of biopsy, the emphasis of scoring system, the emphasis of prognosticating the outcome in tumor patients, and of course the surgical principles as highlighted by Dr. Gautam, right from biopsy to decompression to stabilization to reconstruction using ancillary methods of reconstruction cannot be overemphasized. And of course, embolization really comes handy when you are dealing with some tumors like renal cell, hepatic carcinomas, and thyroid cancers. I hope Dr. Gautam, Dr. Samir, and other panelists, Dr. Priyank, would agree with this summary on this.
Yes, completely. I think just to conclude, sarcomas are most often chemo and radio-resistant tumors. The surgical excision must be complete and early. Even if you don't do an R block, I think one must be a little bit more aggressive, as Guru suggested in this patient, and we may have had a better outcome possibly. So this
Dr.
I
Gautam,
consider as a huge failure on my side. Let's move to the last case. Yeah, tell me.
One question has come up here for you on the chat session. How do we decide which cases to do unblock and which cases to do maximum piecemeal debulking? There's a question for you.
So, according to me, in a patient with metastatic spinal disease, the indication for unblocking it is very, very rare. You really have to be very judicious in unblocking. If there is no systemic disease, is very well controlled, patient is young, healthy, fit, you are expecting a survival of more than 12 to 18 months. The disease is solitary, it's not going elsewhere. Even within the spine, you find the lesion is ideally intracompartmental or at least involving the canal just minimally. Then that is a patient where you will think of unblocking the patient. You must remember an R-block surgery at an average has, even after embolization, has an average blood loss of 1500 cc to 2.5 ml. So it is not a small surgery. It takes 4 to 6 hours to do in the best of hands, and there are multiple issues. So as far as possible, think about a more aggressive decompression in metastatic patients rather than R-blocking them.
Thanks, Dr. Gautam, for highlighting that. Another question, very quick one. After excision of tumors, what are the preferred modalities of reconstruction? Is it bone graft? Is it expandable cages? Or is it cement blocks? Or what are the usual modes of reconstruction in these patients?
So expandable cages are
Dr.
great.
Mihir, after Gautam, you will also have to answer this.
This expandable cages don't fuse very well. And therefore, if you are expecting a long-term survival, I don't like to use expandable cages. I never use expandable cages when I'm doing a corpectomy for a thoracolumbar fracture or something, because that area never fuses at that point. What I prefer is a mesh cage. And when I use a mesh cage, I usually put in a doored cement block inside it and fix the cage into the wedge. There is no harm in using an allograft also, because you are not expecting that allograft to fuse. An autograft is difficult because what happens in most patients, you will require chemo or radiotherapy. And typically we halt the radiotherapy for 3 weeks after surgery, usually waiting for about 10 to 12 days after wound healing and suture removal before we think of radiotherapy. So therefore, if you give radiotherapy at only about 4 weeks after surgery, then the bone graft is not going to really heal. And therefore, it may not be wise to use an autograft. Anybody else is welcome to comment.
Priyank, how do you use reconstruction after excision of tumors?
So if the patient is, if the survivability is going to be long, I've gone for an aggressive procedure, then I would use an autograft. So 90% patients I use mesh cage with cement for those patients who I want immediate stability, and the life expectancy is not going to be that much. But where I've really done a good job and it's a complete en bloc resection, I wouldn't mind using a fibula graft. So I've used it in 10% of my cases. After discussing with the, sorry, I think my internet is a little...
Oh, we can hear you very clearly.
Yeah. So after discussing with the oncologist, because if the oncologist is giving a good life expectancy, then I would not shy away from using a fibula graft.
Tell me which oncologist has not given you a good life expectancy?
Dr. Mihir, role of cement, role of vertebroplasty in patients with multiple Mets. Is it role of vertebroplasty or cementing in multiple Mets? When to do and when surely not to do?
See, I think let us understand, we have been into this discussion of vertebroplasty, kyphoplasty. A cementing is a pain alleviating procedure. It is not for structural stability. Let us first understand that the disease is uncontrolled. It will still collapse around the cement. So if the disease is going to be controlled with chemotherapy and radiotherapy, you can use a cement for better nursing care and better mobilization of the patient because the pain is controlled. Cement cannot be a structural stability on itself. It has to be supplemented with screws and rods. Right. So all these are just pain relieving procedures.
Dr. Samir, one quick question, last one before we move on to the last case of Dr. Gautam. There are situations when you are helpless. There are patients who are moribund, terribly in pain, multiple Mets around, and their survival is still 6 to 9 months. Surgery is not recommended, but they are still in pain. What do you do for these patients?
If they can't have surgery, then radiation for whatever it's worth.
Anything in specific, like any
bone? Vishal, we have to realize when we do surgery for tumors is that there are times when you can't really make the patient much better than what he can, and don't feel pressurized or compelled to try and do some surgical thing just because the patient has pain or patient is demanding. If you think you cannot really do a huge amount of good for the patient, keep your hands on the patient. Don't think that, oh, if I don't do something, how will the patient improve? You're doing something in these circumstances may actually worsen the situation.
I think Dr. Gautam, you're so validly summarized this 2-hour session in one line. Just because there is a session on spinal Mets doesn't mean that everybody from here go and start doing surgery for patients of spinal metastasis. On the other hand, the very fundamental that just because a patient has spinal Mets, so we let him die. No, it is not true. The results are genuinely gratifying. You can really change the course of their suffering. One can really genuinely bring about improvement to their lifestyle for whatever number of years or months they are going to survive. So just don't let them die in pain. There are ways and means to improve their quality of life. At the same time, be very vigilant that you're not overdoing your job by choosing patients undiligently. And that's what is something that this webinar is meant to teach you all, that please choose your patients wisely. Have meticulous and objective patterns of choosing your patient, prognosticate your outcome, and follow the surgical principles. You will surely be able to bring in difference to these moribundly ill patients. Dr. Gautam, your last case before we end and come to the conclusion.
Yeah, so this is a 63-year-old female with no significant medical comorbidity. She had a papillary carcinoma of the breast, for which she had a mastectomy 12 years ago, following which she was 12 months ago, sorry, not 12 years ago, 12 months ago. And she was on some of those, whatever, tamoxifen or some such drug which they give for these things. She had upper back pain radiating along the anterior chest wall, history of low-grade fever, anorexia and weight loss. Tenderness was present in the upper dorsal spine, cervical spine and upper limbs were normal. Lower limb had brisk reflexes, increased tone and plantar extensions. This was the picture on MRI. You can see that the T2 vertebral body has collapsed. There is a hyperintense signal within the posterior half of the vertebral body indicating there is a tumor over there. You can see the axial sections where there is extension of the tumor into the epidural space, causing some tumor-related acquired stenosis. However, there is no significant cord signal intensity change. The hemoglobin was 12 gram per cent, protein count was 800,000, ESR 40, CRP, creatinine and everything normal. The question was, what should we treat this? This is the breast CA, which is that ER-PR positive or some such thing. I don't know what it is. But anyway, so this patient, should we do chemo
and radiosensitive? It means chemo and radiosensitive.
Yeah, so it was chemo radiosensitive. Vertebroplasty should we do? Should we think about surgery here to decompress? She has a mild neurologic deficit. What should we think about in this patient? Let's get some of the other people. Let's get Kedar back again. Kedar?
Yes, I'm here.
Tell me, what would you think?
So this patient, I understand, is ER-PR positive. which means she is chemo sensitive.
She was
so
on
they
chemo
respond
after the surgery also.
Yeah, and if this is a solitary mets with a PET scan which is ruling out any other lesion, then we should seriously think of possibility of en bloc here, because even if we think of en bloc and try to execute it, and we end up spilling a little bit of tumor. There have been studies which have showed that these cases do much better in local control, because an attempted en bloc is much better than a debulking piecemeal, even if we fail with the en bloc.
Kedar, again, let me emphasize this. This is an extra compartmental tumor. Let's not spread the message that en bloc is possible in such case scenarios.
No, but this is only one vertebra involved.
There is epidural extension. There is no possibility of doing a true en bloc surgery here.
Okay.
But Vishal, I think what Kedar meant is attempted en bloc, which is exactly
basically a gross total excision. That is what is recommended, is you visually remove all the tumor that you can see over there and leave everything else to chemo and radiotherapy.
Let's not prompt it en bloc. En bloc requires a wide, clear margin, which here would mean excising the PLL, also sometimes dural extremity. So it is not possible to do it here. Plus, I think one thing for all the delegates, what is emphasized here is, if you saw the sequence of cases that Dr. Gautam has brought beautifully, he brought some cases on renal cell tumor, he's brought a sarcoma, and he's brought now a breast tumor. What this emphasizes is, Dr. Gautam, would you like to highlight why these different type of tumors are having a different kind of discussion in your in case scenarios? Why? What is the importance of all of us paying attention to the type of tumor? Is there a difference in prognosis for them, and is there an objectivity to it?
So as Tomita had pointed out way back, there are tumors such as breast cancer, prostate cancer, which have an excellent or a better, relatively better long-term survival after surgery. And here, the need for a more aggressive surgery is warranted. On the other hand, patients with a lung cancer, a GI cancer like a esophageal or a stomach cancer, metastases, they don't survive too long, and there is no point in doing a very aggressive surgery for them. Also, what is relevant when you see on different types of patient tumors is what is the response of the tumor to normal chemotherapy, radiotherapy, etc. Now, as Vishal well pointed out, that this patient is ER/PR positive, which means she is sensitive to chemo and radiotherapy. So, Vishal, what would you do? We have not answered any question so far, so let's push it to you now. What would you do?
Yes. So let me just take it forward from where you left. Tokuhashi and Tomita scorings are the scoring systems to objectify the prognosis of the era of 1980s to 2010. It is only after 2010 that newer medical management in terms of chemo medicines are available, which have completely changed the way we look at these metastatic tumors. So in this patient, ER/PR being positive, that means this patient has a very, very high survival chances. The age of the patient is also favorable. I cannot really objectify what is the scoring of this patient, but I can really mean that this patient, despite having a met in spine, has minimum survival of 5 years from now with the advent of modern chemotherapy, particularly in an ER/PR positive patient. So having considered that this patient has a 5-year survival, I would surely want to not only decompress it widely with whatever wide margins I can get. Of course, en bloc is not possible, but here a piecemeal excision, complete excision of the vertebral body, leaving behind nothing. Reconstruction using expandable cage along with a graft here, because I know this patient is going to survive a little longer. Though this patient is going to go on chemo, still using expandable cage, all from posterior approach, 2 levels above, 2 levels below, reconstructing it all from behind, excising the whole vertebral body, the disc above and below, using an expandable cage with allograft. I think that will be my surgical plan, following which chemotherapy is something that the oncologist will take over from there. So, and I understand this patient is going to survive really long, Vishal, for more than 5 years.
I understand the survival, but since this patient has a tumor, her problem at present is that she has got a pathological fracture of the vertebral body, but there is a canal, tumor is occupying the canal, and this tumor is sensitive to chemoradiotherapy. Why wouldn't you just subject this patient to only chemo or radio? Why is surgery so essential in this patient?
So if we see the SINS criteria, we know that this patient already has early neurology. And as per the SINS criteria, this patient is surely going to progress in terms of mechanical instability with more than 50% involvement both in the sagittal planes also and in the axial planes also. One of the pedicle on the right side also seems to be affected. Costovertebral junction is also affected. There is plenty of soft tissue around, and the epidural component is also like more than 25% canal compromise is noted. With all these factors, one thing is sure, the predictability of this fracture collapsing further, resulting into neurological worsening, is more than 50%, which I would not want to take a chance upon. And in these patients, one, stabilizing is absolutely must. Now, once I'm going to stabilize, leaving the tumor behind, thinking that everything will be fine with the tumor, I think I would surely want to decompress. Having decompressed, opening up the tumor mass to the cord, rather than just opening and leaving it alone, I would want to excise the whole tumor and reconstruct it and then stabilize to above, below, followed by chemotherapy. Anyway, this is a systemic disease. The disease is not going to be
was seen by somebody else at some other hospital and was started on chemo and radiotherapy. 1 month later, she presented with persistent severe pain, and by now she developed a significant neurologic deficit. Power had gone down to grade 2 from normal in both the lower limbs. Sensations had reduced, and of course, she had upper motor neuron signs. I did a repeat MRI scan when she came to me. There was a further extension of the epidural compression. There was, you can see involvement on both this image. You can see the involvement of the pedicles severely, and she had very significant cord compression. And at that point in time, surgery was the only thing that could be thought of. So I did go in. I did a little bit differently than what was planned. I did a pure posterior as everybody wanted, but I did a decompression, a debulking of the tumor, and this thing, and a posterior stabilization. I did not do an anterior reconstruction. So why operate? The patient operated as per the norms criteria. There is a neurologic deficit, spinal cord compression. There is instability. It is a chemosensitive tumor where we post-surgery will be able to give chemosensitivity. She'll improve. And she is otherwise an active and fit patient where I went in. Probably a reconstruction would have been also well, but this patient subsequently survived for 3 years without any neurological issue, went on to recover completely and did very well. Before I sum up this session, I think I would like, is Samir still around? Samir?
Yes. Yes.
So I think there is nobody better than Samir to summarize a session like this. Samir, would you please summarize the take-home points for somebody else? For all the audience, please.
I kind of missed your lecture, but
no, that's fine.
Yeah. No, so I think the most important thing is you need to be aware that you're dealing with a disease and a patient, and not just with an X-ray and an MRI. I think that is very, very important. So you do need to know the performance factors of that patient. What is the survival? What is the morbidity? What is even the socio-economic status and demands? Like even a 65-year-old person living at Malabar Hill may be playing tennis, and a 65-year-old slum dweller may be towards the end of their life. The second part is the disease is very, very important, because each disease and each metastasis has a different kind of prognosis. And we need to be aware of the prognosis as well as its, how the adjuvants work on it. For instance, if you have a round cell tumor like a myeloma or a lymphoma or an Ewing's or something of that sort, no matter how bad it looks on the MRI, these actually melt away with radiation and with chemotherapy. So, even patients with serious neurological deficits can be treated. One shot of steroids and radiation really just melts away the tumor, lymphomas, etc. So that is important. And there are those on the other side of the spectrum, like renal cell carcinoma, sarcoma, which are very, very, have no adjuvants, like radiation doesn't work at all. And then they may require surgery for neurological purposes as well. So I think selecting the patient is the key thing, and selecting the patient and tailoring the procedure to the patient. I think one important thing is the ability or the ego to do a procedure should not be your guiding point. And I have kept my silence so far on the word oblong, but I am very, I am very negative about that word. I think oblong resection is meant really for tumors which are primary tumors, which are completely contained in the body. So somebody just has a simple back pain, and somebody just has a simple, just 1 second, my battery is dying. Just give me 1 second, 1 second, 1 second.
In the meanwhile, Mihir, any last words? Mihir? Arvind?
Hello, sorry. Sorry, I'm back. So,
Dr. Mihir, you will have to unmute. Dr. Mihir, unmute.
Yeah.
Hello.
So I'm back.
What Samir was saying
I'm back. Sorry. So about
let
O-block.
Samir finish and then Mihir you call.
O-block is really made for those primary tumors like giant cell tumors, etc., which are completely within. The patients who come in the West, they just have a back pain, and you get a tumor which is completely within the body. It does not burst out of the vertebrae either anteriorly or into the canal, and those are the ones which are really for O-block. Metastasis, even if it is inside, like even say all of these who present with neurological deficit by definition have already spread out because they've entered the epidural canal. But even if you catch one which is completely within the vertebra, by definition, once a tumor has metastasized, that tumor is not located to only that vertebra. We are fooling ourselves by saying that it's a solitary met. There is no such thing as a solitary met. It's only a solitary detected met. There would be other micrometastases which are going to grow, and the whole grading of that cancer completely changes. So it cannot be a curative procedure. Now, to do such an intense procedure like an en bloc, unless it's a curative procedure, I'd be really hesitant to do it. So you can do it, okay, as a surgical skill, as your ego, or maybe to practice for the simpler cases. Sorry to be so blunt, but you can't really say that I'm doing an en bloc for metastasis and doing something which is great. In short, it's a very complex topic, and Gautam has laid many of the principles, but it's basically, there is no tailor-made thing. You need to follow all the principles before you make a decision for a particular patient.
Right. Thank you, Samir. Mir, I think very nicely summarized by Samir. Mir, any additional thoughts on these? And then can I call Kulkarni also after that?
Yeah, as a spinal surgeon, you just need to fit yourself into a position of treating the whole gamut of the disease. And you have to intervene in terms of the pain, the instability, and saving the neurology. But all this has to be in conjunction with the medical oncology team. That means you have to have a very realistic view whether surgery is the only thing or there are other things which can matter in the prognosis of this tumor. And like Samir said, you should just keep your ego back. You are not the only person who's treating this disease. There are too many people at one time treating this disease. And the patient itself matters the most. So I think you have to be very, very realistic and try to achieve one goal, not try to cure the disease.
Thank you. Arvind Kulkarni, are you there?
I think Arvind is not there. Ranjit, Umesh, Ranjit and Guru, who are our panelists, maybe they can have a word each on
Umesh Shrikant is there. Umesh, a neurosurgical perspective
Umesh.
To this.
Yeah, hi. So one more situation I would like to just bring up. I don't know what you guys would suggest. So because we see some cases of lymphomas which are quite extensively involving the vertebral body. And in all these cases, the primary treatment will all be radiation, radiotherapy. So our oncologists have recently started asking us that, once they give the radiation therapy, this entire kind of tumor kind of dissolves and they are left with a hollow tumor, and they have seen quite some cases of instability or collapse after they have started radiation. So my question here, or my doubt here was that, so at what point would you like to intervene in these cases? Would you like to, they have even asked us whether we want to fix them prophylactically, because the tumor is quite extensive and there is a very high chance of a very large void being left behind after they have given radiation, because you already told that those tumors kind of dissolve on their own after radiation. So at what stage would you like to intervene? Like, would you really like to do a prophylactic fixation, or would you like just to wait and see how the whether if there is an impending collapse or if there is a void after this radiation therapy?
So
that's going, and
I will say that two things.
So basically,
over to Vishal, because Vishal
versus surgery
after talking about this. But lymphoma and myelomas don't fulfill the criteria of all these things. They don't fall. All the criteria which have been described are for secondary tumors. Lymphomas and myelomas are primary hematologic malignancies which do not fit into this criteria of instability because of so much of destruction, etc. Besides lymphoma and myeloma, the bone tends to regrow with time after your chemo and radiotherapy. They're extremely exquisitely sensitive, lymphoma is. In fact, the worry is sometimes if you have a primary of unknown origin, patient comes with a neurologic deficit and you give them steroids, and then you open up the patient, the lymphoma may have disappeared by then because it is so exquisitely chemosensitive. But I don't see that there is that much need per se the principles still apply that if there is a lot of tumor occupancy, you may think there is no clear guideline available for that. And I don't think anybody has a huge experience on operating lymphomas because most of us treat them with chemo and radio.
So usually, yes, usually the limited lymphomas, it's not a big concern at all. But I was talking about spread lymphomas, which are like involving the entire body, which are partially extending onto the pedicle and all those things. But there is no sign of clinical instability because they are still. So even in those cases, like and we know that after radiation, these tumors dissolve quite fast. And is that time gap enough? See, this is a concern that we had in one of our discussions with our oncologists. So they were of the worry that, once they give radiation and this entire tumor dissolves, so there may not be enough time for this bone to regrow. And they have seen, apparently, they have seen some cases where they have had post-operative,
I think Gautam highlighted this point in his lecture very well. So if you really preempt something and you have your goal, you have your fixation points very well available to you, because in such extensive disease, you may not have fixation points. So if you have fixation points in front of you, a minimally invasive stabilization, and then continuing with your sort of radiation, and then watching the aftermath of radiation, and then treating it secondarily. So that also can be done. But the question is, you should be very clear of your goals. And that should be in discussion with your radiologists and your oncologists.
Yes.
Umesh.
Yeah.
Umesh, Guru. One thing we have seen here that the CT scan helps in these scenarios. When you do a CT, like if you see a shell of bone just remaining there, and all the trabecular material has gone, and it is eaten up, and it is like a kind of a picture like ABC you see in these lymphomas. So in these lymphomas, usually what our oncologists say that you fix them up prophylactically and then they give radiation. So I think CT helps in these scenarios.
Yeah, in lymphomas, most of the times the CT is going to show a big void, like there is going to be a big.
So but then it shows how much of the body is already eaten up, actually.
Yeah.
I think
we'll have to
in the stop now.
Interest of time. Yeah. In the interest of time, we will have to stop. And before we leave, I would like to thank all our panelists here who came across from the parts of country. Guru Raj from Delhi, Umesh from Bangalore, Ranjit from Kerala. Thank you so much, guys. And all the Bombay Spine Society senior members, Dr. Mihir Bapat, Dr. Sameer Dalvi, Arvind Kulkarni, and above all, Dr. Gautam Zaveri. Thank you so much for sparing your time. I'm sure we are going to have many more such sessions coming up in the future. Unfortunately, this day has not really been great for the country, where we are seeing 250 cases already getting added to the corona. I really hope, wish and pray that things are settled down so that we don't have to do these webinars. We can directly have one-on-one interactions personally on a physical basis. Unfortunately,
I'd just like to share my email address with the participants of the session. It is Gautam, Gautam Zaveri, Zaveri 1969 @gmail.com. In case anybody wants to communicate with me with questions, I would be happy to answer. I would like to thank the Bombay Spine Society for giving me this opportunity. I would like to thank you for actually arranging this and inviting me. And I would like to thank all the panelists for their time. Thank you. I'm cutting off now.
Thank you so much. I've shared the email ID of Dr. Gautam on the chat show. Everybody is more than welcome to catch it from there. We have with us Dr. Priyank Patel, who is in Mumbai, Jupiter Hospital, and is very, very aggressive and known for his tumor surgeries very well. Thank you, Priyank. Dr. Amit Sharma, who's again another very senior guy in Bombay Spine Society, contributing to this webinar. We had Dr. Sameer Dalvi, Dr. Ranjit Unnikrishnan, and unfortunately, we were not able to catch Dr. RK from Muscat, who's another big guy in tumor surgeries. Unfortunately, because of internet issues, we are not able to see him. Probably in the next sessions, we'll be able to catch him, of course. Thank you so much. The article shared today will be shared on the YouTube, on the WhatsApp group by Dr. Saijot Raut. If any questions, any queries, please don't hesitate to write back to Bombay Spine Society, any of the members. They are also there on the WhatsApp group, and we have shared the email ID of Dr. Gautam Zaveri. Before we end, tomorrow we have another interesting session on spinal injection techniques in lumbar spine and cervical spine by Dr. V.T. Ingalalika, where we'll have another national panel to be on the expert panel for the session. And then in coming days, we have sessions on cervical myelopathy, by Dr. Mihir Bappa, Dr. Sameer Dalvi, Dr. Nikhil Arbati on Friday. And on Saturday, we have another session on spinal instrumentation, back to basics, A to Z of instrumentation systems on Saturday. On Saturday, the session runs from 12:30 to 2 instead of in the evening. It is from 12:30 to 2 o'clock. Looking forward to see you and host you on web by Bombay Spine Society. Thank you, guys.
Thanks, Gautam. Bye.